pleasant day to everyone. I am Kathleen Labitagbak and I'm going to discuss all about the cor pulmonale or the pulmonary heart disease. So the content of my topic contains first the introduction and then the signs and symptoms, the laboratory and diagnosis, the pathophysiology, the treatment algorithm, the surgical, medical, and pharmacological management, the nursing management, and then the prognosis. So first, let's get to the topic. So cor pulmonale is also called as right-sided heart failure, is a condition in which the right ventricle enlarges with or without right heart failure as a result of a disease that affects the structure and function of lungs or its vasculature. So pushing against high pressure can cause your right ventricle to fail. So most cases are chronic and long-term. So, the most frequent causes of cor pulmonale is the chronic obstructive pulmonary disease or the COPD. So, let's move on the pathophysiology of the cor pulmonale. So, cor pulmonale is caused by respiratory diseases, for example, the COPD and other lung diseases, causing airway to be thick, inflamed, and produce mucus. Mucus can clog the airway, making it harder to patient for a breath, leading to inflammation, fibrosis, and hypoxia, causing pulmonary vascular bed destroyed or obstructed when the air sac or the alveoli, which is elastic and flexible in nature, becomes floppy broken and lose their shape as the air spaces gets larger. Air gets trapped and there are fewer air sacs to supply oxygen to the blood because air is trapped in these air sacs. It is difficult for lungs with COPD to deflate like normal lungs. This trapped air makes it harder to get fresh air into the lungs and makes breathing more difficult, in which there will be increase in arterial stiffness, endothelial dysfunction, and vascular remodeling. There will be persistent pressure and resistance in pulmonary artery, which is called pulmonary hypertension due to lung diseases. So the right side of the heart being unable to pump blood out of the ventricle and into pulmonary arteries, which we have an increase in right ventricle after load. So basically, the right side of the heart is pumping against a lot of pressure. So the right ventricle will increase in size, which we call the right ventricle hypertrophy, to effectively pump the blood out of the arteries. So this strain on the right ventricle trying to pump blood against high resistance, making the right ventricle to fail, leading to a back pressure of blood, leading into the right atrium, the vena cava, and then the cystic nervous system. That's what we call the cor pulmonale. The symptoms are usually those of the underlying lung diseases. So first, the clinical features such as the COPD or the chronic obstructive pulmonary disease, the shortness of breath, and a cough. So next is the right ventricular failure develops such as edema on feet and legs, distended neck vein, enlarged palpable liver, and then the pleural effusion, ascites, and a heart murmur. Next, we have the headache, confusion, and somnolence from carbon dioxide narcosis may occur. For laboratory and diagnosis, so here are the tests to diagnose cor pulmonale. It includes the echocardiogram or the ECG, the chest X-ray, the electrocardiogram or the EKG, and then the nuclear medicine imaging, the CT angiogram, the heart MRI, the VQ scan, and then the right heart catheterization. So for medical management, oxygen is provided to reduce pulmonary arterial pressure and pulmonary vascular resistance. Continuous 24-hour per day oxygen therapy is provided for severe hypoxia. Blood oxygen levels are assessed with pulse oximetry and arterial blood gas or ABG analysis. Bronchial hygiene, bronchodilators, and chest physical therapy may be instituted if respiratory failure, intubation, and mechanical ventilation may be necessary. For another medical management, if heart failure occurs, hypoxemia and hypercapnia must be reduced to improve cardiac output. So peripheral edema and circulatory load of the right side of the heart are reduced with bed rest, sodium restrictions, and diuretics. If indicated, for example, the left ventricular failure, digitalis are given. The electrocardiogram or the ECG is monitored. Pulmonary infection must be treated promptly because it will exacerbate hypoxemia and cor pulmonale. For surgical management, pulmonary embolectomy in unresolved emboli, heart-lung transplantation in patients with primary pulmonary hypertension, unilateral lung transplantation in patients with lung diseases. So for pharmacological management, first we have the bronchodilators, the corticosteroids, the diuretics, the anticoagulants, the pulmonary vasodilators, the digitalis, the beta blockers, and then the sildenafil. For the nursing management, if required, assist with intubation and mechanical ventilation, and then support patient physically and emotionally. Then assess the cardiac and respiratory status, then instruct patients about the importance of close monitoring and adherence to the treatment regimen, especially the oxygen, and then explore and address the factors that affect the patient and their adherence to the treatment regimen. So for another nursing management is to advise patient and family that the management is long-term and that most care and monitoring will be performed at home for this chronic disorder. And then advise patient to avoid activities that can irritate the airway if COPD exists, and administer continuous oxygen and instruct how to use it, and then urge patient to stop smoking if appropriate, refer patient to smoking cessation or to community support group. So for the last, nursing management, counsel the patient about nutrition if sodium restricted diet or diuretic medication is part of the treatment. If patient's physical condition warrants close assessment or monitoring, or if patients can't manage self-care, refer the patient for home care. So lastly is the prognosis. So the prognosis of cor pulmonale is variable depending upon the underlying pathology. So the development of cor pulmonale as a result of primary pulmonary disease usually heralds as poorer prognosis. So for example, a client with a chronic obstructive pulmonary disease or COPD who develop a cor pulmonale have 30% chance of having 5 years. So whether a cor pulmonale having or carries an independent prognostic value or simply reflecting the severity of underlying COPD or other pulmonary disease are not clear. So here are the references that you can use as future references and for your future studies.